Hello and welcome everyone. Today we'll be discussing about viral pneumonia and its impact in ICU. So there is a growing challenge of viral pneumonia in the ICU. Respiratory viruses are widespread in our community. They affect both the upper as well as the lower respiratory tract. They are increasingly getting detected in critically ill patients with reports of prevalence of around 50%. They frequently cause of ICU admissions, typically presenting as respiratory failure with or without a pneumonia. The clinical presentation is often non-specific, so making the etiological diagnosis is challenging without any advanced tool. This presentation focuses on immunocompetent adults admitted to the ICU for community-acquired severe acute respiratory tract infections caused by viruses. We have excluded COVID over here. Regarding the epidemiology, the advent of molecular diagnostics, that is the multiplex PCR, has significantly reshaped our understanding of the respiratory viral infection epidemiology since 2007. The key findings are respiratory viruses are implicated in around 40% of the community-acquired pneumonia hospitalizations. They are the frequent triggers of decompensation in patients with chronic respiratory comorbidities. The principal viral pathogen associated with severe outcomes are influenza A and B, pneumoviridae, that is respiratory syncytial virus, and human metapneumovirus. Other frequently identified viruses are picoRNA virus like rhino, enterovirus T68, human coronavirus, parainfluenza virus, adenovirus, and emerging zoonotic infections like SARS, MERS, COVID-19, they also are continuing. Some viruses follow seasonal pattern while others circulate all the year round. The impact of molecular diagnostic. The benefits are it allows a simultaneous detection of a broad spectrum of respiratory viruses. The improved pathogen identification at the bedside. Available platforms demonstrate positive predictive agreement exceeding 95% compared to the gold standards. The challenges, though, are the clinical relevance is uncertain. Though we do get reports, this detection can range from true pathogenicity, which means that the viruses that we have detected is actually causing the symptoms, to the incidental colonization, which can happen, or maybe even a transient carrier, depending on the virus, the person's host's immune status, the timing of the sampling, and the sampling site as well. All these things can make the difference between a pathogenicity to a carriage to a colonization. Nasopharyngeal PCR may lead to underdiagnosis, false negative despite the lower tract getting involved, or overdiagnosis where asymptomatic carriers are seen because of the viral setting. Co-detection of bacterial and fungal pathogens is very common over here. Now, advanced platforms like the film array pneumonia panels, currently the only multiplex PCR platform that includes the 8 viral targets alongside bacterial targets. It can identify nearly twice as many viral pathogens as standard care testing, partly due to the broad sputum testing. The clinical utility remains uncertain though because of the heterogeneity in the study populations that have been done till now. So in conclusion, while the multiplex PCR pneumonia panels can provide a useful clinical insight, particularly in critically ill patient, the decision how to interpret the reports is entirely a clinical decision, and the patient's outcome needs to be clearly established based on these findings. Now, these are the various panels that are available and the viruses that they are testing. So these are the PCR and with their turnaround times. The pathophysiology of viral induced lung damage. They cause epithelial tropism and viral induced cell death. The respiratory viruses, they demonstrate a marked tropism for the epithelium, thus infecting both the upper and the lower respiratory tracts. The influenza targets the ciliated epithelium and extends to the secretory and the alveolar epithelium as well, the exacerbating damage and contributing to the alveolar collapse. The syncytial virus and the metapneumovirus compromise the epithelial barrier by disrupting the tight junctions and impairing the ciliary functions. Virus-induced cell death, that is apoptosis and necrosis, exacerbates the epithelial damage, impairing the repair mechanisms and the respiratory integrity. They also cause immune dysregulation and inflammation. The viral infections, they trigger an immune response which is essential for the clearance, but this can also cause immune-mediated lung injuries. The influenza induces macrophage and dendritic cell activation, leading to what is known as the cytokine storm, which we saw so commonly in the COVID-19 infections. That amplifies the inflammation, causing damage to the body, especially the lungs, like diffuse alveolar damage and ARDS. The syncytial virus, it activates toll-like receptors, produces chemokines like interleukin 6, 8 that recruits neutrophils and monocytes, which release reactive oxygen species and proteolytic enzymes, exacerbating the epithelial injury. You also have altered macrophages and CD8 plus T cell functions. Though macrophages can adopt a pro-inflammatory phenotype, and excessively activated CD8 plus T cells can cause tissue destruction as well as fibrosis. Regarding the histopathological evidence that we have, there is evidence of necrotizing bronchitis, bronchiolitis, diffuse alveolar damage with hyaline membranes, alveolar edema, inflammatory cell infiltration. These are essentially the hallmark of a viral infection. The epithelial disruption facilitates the secondary bacterial infections, particularly with streptococcus and staph, further worsening the lung damage. Severe respiratory viral infections are frequent cause of ICU admission, primarily acute respiratory failure with or without a pneumonia. So, non-pneumonic acute respiratory failure is often linked to exacerbation of the underlying comorbidities like a COPD or a cardiovascular condition. Now, systemic complications or the cardiovascular events are like in respiratory syncytial virus, in adults more than 50 years, 23% experienced acute cardiac events like a heart failure or an ischemic event or a hypertensive crisis. In influenza, there is a nearly 10-fold rise in myocardial infarction risk and a 12-fold increase of stroke risk during the first 3 days of the infection. Community-acquired pneumonia, the viral etiologies are identified, as we have said, in around 40% of the cases. The clinical presentation here is typically fever with cough, there is myalgia, anorexia and headache, with median incubation period of less than 7 days. Now, this presentation is neither specific to the viral etiology nor sufficient to distinguish it from viral to bacterial. What probably happens is there is initial viral infection which causes the epithelial damage, thereby making the person more prone to the viral infection. Thus, the viral bacterial co-infection happens, and it is reported in around 25% of the cases, which are associated with more severe presentation, higher rates of sepsis, and the need for mechanical ventilation. Bacterial sampling remains crucial to guide timely antimicrobial therapy, even when a viral pathogen is identified. The outcomes, the severity and the prognostic factors. Regarding the severity profile in ICU settings, the viral community-acquired pneumonia exhibits a severity profile which is comparable to bacterial pneumonia, with a median ventilation duration of around 7 to 10 days and a mortality rate around 10 to 30%. The high-impact viruses are influenza and respiratory syncytial, which are consistently associated with severe outcome, ICU admission and mortality. The ICU length of stay for the two viruses are comparable, around 7 days, with mortality also similar, around 25 to 30%. The human metapneumovirus is also linked to severe outcomes with ICU admission rates of around 10 to 30% again, and your early mortality of around 3 to 10%. Viruses with less clear pathological potential, in immunocompetent especially, are the adenovirus, which rarely causes a severe outcome, the para-influenza, which usually causes mild disease, a very rare of around 3% ICU admission, the seasonal coronaviruses, and the human Boca virus, which rarely causes a severe pneumonia. Rhinovirus data is equivocal with estimated ICU mortality of around 30%, but it is often a co-infection or the patient has an underlying condition. The critical determinants, what exactly tells us that there is going to be a worse outcome? The first and the most important is a bacterial co-infection. As we have already discussed, it is seen in around every 1 out of 4 patients and associated with higher mechanical ventilation rates as well as mortality. A meta-analysis has shown twofold increase in mortality rate if there is a bacterial co-infection. The cardiovascular complication cannot be underestimated. We have already discussed this. There is a very high risk of ICU admission, mortality because of the increased risk of myocardial infarction as well as strokes. The population who are at this risk is definitely the older age and pre-existing comorbidities, very similar profile to what we saw in COVID-19. Regarding the management aspect, the first would be no doubt the non-invasive respiratory support. The lessons that we learned from the COVID-19 were that the pandemic re-established non-invasive as a central component of acute respiratory failure treatment, especially the high-flow nasal cannula. The COVID-19 cohorts were associated with reduced risk of oxygenation failure compared to standard oxygen, and the COVIDicus ICU trial has showed no significant difference in 28-day intubation rates between HFNC, CPAP, and standard oxygen. The meta-analysis, however, showed a reduced escalation to invasive and non-invasive for once you use HFNC, but there was no impact on hospital mortality. If you go for the non-invasive, in COVID-19, the NIV was associated with increased 90-day mortality. This was mainly because of delaying the intubation rather than because of the NIV itself. If you look at the evidence of non-COVID-19 viral pneumonias, non-randomized data specifically addressing non-COVID-19 pneumonias shows that extrapolation from a broader patient into acute hypoxemic respiratory failure must be done. While HFNC here appears to be safe and may reduce the need for intubation, the current evidence is actually not very strong, neither supportive of it. The recommendation is therefore outside of the well-established indications of the NIV. The choice of respiratory support is empirical and has to be subjective, and whenever you are doing or starting the patient on HFNC or NIV, please use your scores, which will help you in understanding whether they are failing. We do need dedicated RCTs to evaluate these modalities in especially viral pneumonia. Regarding antiviral therapy, neuraminidase inhibitors are the cornerstone in severe influenza. Despite limited evidence in critically ill, oseltamivir is our primary therapy. Oseltamivir efficacy and the considerations should be remembered. The hospitalization patients, a recent meta-analysis reported no significant difference in mortality and reduced hospital stay by around 1 day, which is not much significant. In OPDs, there is no reduction in the hospitalization risk in both general as well as high risk. So the optimal duration can be 5 days versus prolonged. Observational studies suggest that extended therapy may yield outcomes in ICU settings with 6% absolute reduction in mortality. But again, these are very low quality observational trials. We need RCTs. Resistance is rare, less than 1% globally. Coming to the other inhibitors, that we have peramivir, which has no significant difference in outcome compared to the oseltamivir, and it's a second line to oseltamivir. Says if there is resistance and when oral administration is not possible, it's given IV. You have inhaled and IV zanamivir, which has no significant difference again with oseltamivir. You can consider it as a second line. You have novel agents like Boloxavir, which targets distinct viral replication pathways and has shown superiority in hospitalized patients. The Flagstone trial confirmed no clinical advantage of it over the NAIs, rather the monotherapy versus combination, and may be considered as a second line to oseltamivir if there is resistance. Ongoing research, we have trials like REMAP-CAP, which are expected to provide more clarity on optimal antiviral strategies. If you look for respiratory syncytial virus, there is significant challenge. You have ribavirin. It has been historically considered but has demonstrated inconsistent efficacy and potential toxicity, limiting its role particularly in immunocompetent patients. It has shown reduced mortality in lower infection in patients who have malignancies and stem cell transplants. The prophylactic monoclonal antibodies are explored in infants and high-risk children, but their therapeutic potential in adults is still unproven and obviously needs further investigation. You have some emerging therapies like zelicapavir, which is currently under evaluation in older adults with cardiovascular comorbidities. Uh, we need more robust trials which are still awaited. Next, you have the adenovirus. You have pseudofovir, though we have weak evidence with some case reports in pediatric patients suggesting potential effect on adenovirus clearance in immunocompromised patients associated with adverse events like nephrotoxicity and leukopenia. For other respiratory viruses, the most other respiratory viruses, effective antiviral therapy is essentially lacking. So the primary approach is supportive, which remains the cornerstone, like oxygen, ventilatory strategies, vigilant monitoring for bacterial infection. In future, there is promising investigative agents being looked for, viral fusion proteins, replication pathways, which may be a target and potential antiviral for us in the future. Immunomodulation with steroids is highly debated aspect. General CAP context. The Cape Cod trial demonstrated a mortality reduction with low dose hydrocot in severe CAP. The subgroup analysis did not specifically address the viral etiologies. Influenza, the observational studies and meta-analysis have consistently indicated that steroid is associated with increased mortality and higher rates of infection. Though there is a caveat, this finding must be interpreted cautiously due to the absence of high quality RCTs and the potential for confounding by the indications. That is, steroids are often used for other indications in critically ill patients. Regarding the viral respiratory infection, the data on steroid use is limited with no RCTs at all. The recent individualized patient meta-analysis by Smith, which without showing no statistically significant heterogeneity based on microbiological etiology, the point estimate of mortality reduction consistently disfavored steroids in viral infections. But you must keep in mind that in COVID-19, the steroids were definitely center of our treatment modality. So a lot of things matters, especially which type of symptoms and how the symptoms are developing. So steroids should be considered, and we need more trials on this. So trials are ongoing with steroids and other immunomodulatory therapies. As I said, in clinical decision making, until we have something robust coming in, it has to be individualized. Regarding the prevention, the vaccination remains the most effective strategy, especially in high-risk patients like elderlies. Influenza vaccine, it is effective in largely dependent on the antigenetic matching. The greatest benefit is observed in individuals more than 65. The reduced risk of confirmed influenza and influenza-like illness in this population is around 5 to 3%, and it's associated with reduction in pneumonia as influenza-related deaths, and is estimated to prevent thousands of deaths annually in older adults. Regarding the syncytial virus vaccination, a newly approved vaccine is available for older adults. In the real world data from 23 October to 24 March, in individuals aged more than 60 years, they demonstrated high effectiveness. 77% against the syncytial virus emergency department visits, 80% for hospitalization, and 81% against admissions into ICU and subsequent death. Measles vaccination, it is crucial because it's a re-emerging threat. So ensuring high vaccination coverage for the disease of measles is critical. We already have seen around 220 cases of measles in March of 2025 in the United States. Measles is highly contagious and potentially fatal. So the recommended two-dose vaccination strategy will provides around 99% protection. Even in immunocompetent patients, pneumonitis is frequent. Acute respiratory failure requiring ICU admissions is seen in 3% cases. Critically ill patients experience such and more severe disease with mortality. It doesn't have any antiviral treatment for it. Regarding the future risk, post-pandemic effect, the immunity debt is there. COVID-19, the non-pharmacological interventions led to unprecedented decline in the pathogen circulation, and this limited the natural immunity development and combined with reduced vaccine uptake created an immunity debt, heightening the risk of severe post-pandemic outbreaks, which we have already seen multiple times. There have been recurrences of it happening, which is linked to the antigenic drift, and more intense epidemic could be there, resulting in travel restrictions. Regarding the emerging threats, it is driven by the environmental changes, the globalization, the evolving pathogen characteristics. The novel coronavirus, SARS, MERS, and the COVID-19 underscore the potential for new pathogens to cause severe outbreaks with high mortality. The highly pathogenic avian influenza, a persistent concern, particularly strains with pandemic potentials, are associated with 90% hospitalization and more than 50% fatality. The arbovirus, dengue, chikungunya, they continue to expand geographically due to the climate changes, the mosquito vectors, the growing urbanization, and it's currently affecting lots of parts of the globe. Regarding the conclusion and future direction, the key takeaway is severe respiratory viral infections remain a major cause of ICU admission and contribute significantly to morbidity and mortality, particularly in the older adults with comorbidities. Regarding the multiplex PCR, we are detecting the viruses more commonly, but we need to understand whether they are colonizers, carriers, or actual infections. And the infections of the viral can also lead to bacterial co-infection, which can also worsen our outcomes. We have very few therapies available, so most of it is still in research process as of now. So the primary treatment remains supportive, that is oxygen, immunomodulation, like that. Thank you for your patience.